All right, so like Dr. Spear said, I'm going to be talking more about the specifics of the protocol that we use for patients with shoulder instability and who have undergone labral repair or capsular reconstruction. Like Dr. Spear said, we don't see these patients after just a couple of days in the sling. We are not even seeing them in the clinic until it's been about 3 weeks following their surgery. So what we'll be talking about tonight is specific to Dr. Spear's protocol, and like he said, there are many different ways to go about this, but the main overarching theme of this is that there are specific guidelines that we should follow to be respectful of the surgical repair that has been done. At the end of the day, we need that surgical repair to be completely solid in order for that patient to have full function of their shoulder. So we need to be mindful of this as we go about our rehab process with them. So for this reason, we have a very deliberately paced protocol, and that it is a protocol that really respects the amount of time that has passed since the surgery itself, and not really the patient's level of pain and how they're if they're feeling wonderful, that we can continue to progress them along. We're really being mindful of how much time has passed since the surgery. So the beginning of the protocol is really the time that they're spending outside of the clinic. So they haven't even come to physical therapy for the first 3 weeks. We keep them in a sling from 0 to 3 weeks, and to immobilize the shoulder, and making sure that the repair that has been done stays safe, and that we know that during this time, of course, there's going to be some sort of stiffening that occurs within the shoulder. The repair that has been done, of course, is the number one thing that we're trying to protect. So we accept some sort of stiffening that's going to occur, knowing that the repair will stay safe during this time. The patient is, however, encouraged to actively, at times, move the elbow and the wrist and hand so that any stiffening in these more distal joints is prevented while they're in the sling to immobilize their shoulder. So phase 2 is when they actually begin physical therapy. So 4 to 7 weeks, this first month of physical therapy, this is really a very protective phase. I think it's really important, the protocol itself is really important for us as physical therapists to recognize and to respect, but also it's helpful for us to educate the patients on the parameters of the protocol as well. So from the very beginning, I think it's important that we are educating on the patients on the purpose of PT and the goals that we have for the first month and then the subsequent months as well, and sort of kind of spelling out the timeline that we'll be going through, and so that way they know from the very beginning that even if they are this star patient who achieves certain amounts of range of motion early on, and that they feel great, that with that, that's wonderful, but we are still going to be mindful of the fact that it's only been, a couple of weeks since their surgery, and that we won't be progressing faster than what the protocol allows. Of course, they've been in the sling for 3 weeks, and at this point now we can start to do some early range of motion exercise with them, and this is part of the healing process as well, and the early motion of the joint helps to facilitate healing too. So during this phase, the limits that we impose on the patient, they are not permitted to lift anything in their the hand that weighs more than 1 pound. Or use more than 1 pound of force with that hand. So opening and closing doors, or pulling themselves forward at a table, things like that could disrupt the repair. And then the other limits that Dr. Spear mentioned as well. So we're talking about limits to the amount of passive range of motion that they're going through. So active or elevation of the shoulder is limited to 140 degrees, external rotation to 40 degrees, and internal rotation to the level of L1. And we'll go into those details a little bit more later on as well. The patient is also, at this point, we limit their active motion. We want to keep them in passive motion and some active assisted more later on in this phase 2. And so we're really preventing them from doing any kind of active motion at this time. So no sling wear, we take off the sling, but still not really using the arm for daily activities. At this time, I think it's important to make sure that we address the pain and inflammation within the shoulder so that the patient, number one, with less pain, there's going to be less guarding, and the patient's going to feel a lot more comfortable working with the therapist in the clinic, and also is going to be much more likely to achieve their goals during this time if we're really being mindful and respectful of their post-operative pain. So from the moment that they come into the clinic, we can make some observations as to sort of what they've been up to over the past 3 weeks since their surgery. Some patients present wearing their sling, they're very guarded. They tend to, certainly have not removed the sling and been doing anything with their shoulder over those 3 weeks. On the other hand, there are certainly patients that come in and say that they've already taken off the sling and they've already been doing X, Y, and Z. They come in carrying their purse or their laptop with them with that arm, and so from the very beginning we kind of get a sense of what they've been doing over the past few weeks, and also how much we need to guide them in terms of pulling back the reins or and educating them on what our protocol and timeline is going to be for the next few weeks and few months. The patient history, I think, is important with this patient population because with instability and specifically dislocations or subluxations, that patient is probably going to have some degree of apprehension. So they may be a little bit more apprehensive of working with a therapist, or certainly having that therapist hold their arm or move their shoulder. So we want to be respectful of that and understanding of what that patient has been through prior to the surgery. At the evaluation, of course, we can assess their passive range of motion. We won't be looking at active motion until further down the road. But of course, we're going to be looking at what limits their passive motion. So is the joint stiff, or is the infield empty and they're limited by pain, but very little stiffness. So we can assess that at this time. And one thing just to check as well is elbow and other joint stiffness in that extremity, just making sure that there hasn't been joint contracture happening because of the sling wear. All right, so with respect to the specifics of the limits to the motion, that passive motion that we can permit at this time, elevation at 140 degrees, external rotation at 40, and internal rotation to the level of L1. So these are our upper limits to the amount of motion that we can go through, and they're not necessarily the goals that we're trying to achieve at this time, but really the boundaries that we're trying to respect. So if we achieve these positions very early on in this phase, no matter how that shoulder feels, if the patient feels great, there's no pain, there's no stiffness at these points or prior to that, we're still not moving forward. We're in a holding pattern at this point. So we can be happy that we've reached that point, and maybe the patient doesn't need to be seen in the clinic as frequently as somebody else until later on, but we won't be moving forward in terms of doing any kind of a more aggressive strengthening or more aggressive motion stretching kind of exercises. I think sometimes it's helpful to educate the patient on the specific limits that we're stopping at, and for patients, most of them don't know what 140 degrees of elevation or 40 degrees of external rotation is. So I like to give them an illustration of what this means for a specific exercise, say, that they're working on at home, so that they know that when they get to a certain point with this exercise that they'll stop there, because their shoulder isn't necessarily telling them that that's where they should stop. So giving them some sort of illustration of this, I think, is helpful, and it also lets the patient know what we're working towards, but being still respectful of the repair that was done. And this also goes the other way too, that if the patient is having pain prior to these limits and we're working on stretching them in the clinic, we can sort of reassure them that we're not stretching through the repair, we're not tearing apart the surgical construct. If we're still at 40 degrees of elevation and they're having a lot of pain, that repair is still safe. They're experiencing post-surgical discomfort and scar tissue that's been formed since the surgery. So I think that helps to sort of set their mind at ease too, that and trust what we're working on as well. So treatment during this time, we'll definitely work on stretching and trying to progress their range of motion. The shoulder definitely lends itself to manual therapy in the clinic, so manual stretching, and then also providing them with home exercises that they can work on to help to achieve gains in range of motion. Strengthening exercises can be performed during this phase, and we can start to incorporate some very light isometric, maybe rotator cuff exercises, and also periscapular exercises. As Dr. Spear talked about, the cuff and the musculature of the shoulder really provides that stability and the support of the joint, and so we want to make sure that we're addressing that and keeping that in mind as well. During this first month of therapy, joint mobilizations can be performed. We stick to mainly grades 1 and 2 mobilizations, with the aim being that we're trying to reduce muscle guarding, reduce pain, not that we're getting into the range where we're feeling any kind of joint stiffness and restriction. So we're staying really in that early part of the joint motion. There's a multitude of exercises that we can perform, and really with the protocol, this isn't really a cookie cutter approach to you perform this exercise, this exercise, this exercise. The goal of the protocol is really just to provide boundaries, within which you can choose specific exercises that you like. But just for example, there are many passive stretches that you can work on to achieve whatever range and direction of motion that the patient requires. Scapular clocks to work on scapular stability and building muscular support around the scapula. Active assisted motion can be initiated during this time, usually more towards the end of the first month. Working on maybe elevation in supine. And like I mentioned earlier, rotator cuff exercises can be performed too. Aquatic therapy, I think, can be very helpful for these patients, especially patients who have a lot of pain or a lot of guarding with therapy on land, and also patients who just like to be in the water and who maybe were doing aquatic exercise or swimming before the surgery, that they're very comfortable there. So their muscle guarding is reduced when they're in the water. The buoyancy of the water really helps to support the arm and make the shoulder relax a little bit better. So sometimes this exercise is really nice in conjunction with, or exclusively with the land exercises. All right, so moving into phase 3, this is our second month of therapy. The range of motion is still going to be something that we're looking at and something that we're trying to progress, but within the being respectful of the fact that the purpose of the surgery was to increase the stability and keep that shoulder tight. So with patients who are a little bit erring more on the tighter side, that's good, and that's okay in this phase. In fact, we're really not trying to push towards full range of motion and stretching the shoulder to its full range until after 10 weeks. So that's midway through this third phase. So we're still not trying to go very aggressively and stretching them or as soon as we enter the second month of rehab. In this phase, we certainly can begin to do joint mobilizations that are into the joint restriction, so we're getting into grades 3 and 4 if necessary. And so, particularly maybe speaking to the internal rotation deficit, where the posterior part of the capsule becomes tight, that these mobilizations can be pretty effective in this phase where we're really working to make sure that we're preventing that the head of the humerus from shifting anteriorly because of the tightness posteriorly. Scapular mobilizations can also be performed here if necessary. And then treatment for addressing range of motion, we're going to be advancing maybe the exercises that they're performing at home, any kind of stretching exercises, working in whatever direction that they need. Strength training is essential to the patient with instability and a history of instability. And we typically work from the inside out. So we work on beginning with the nice foundation of rotator cuff strength and beginning there, and then working more towards the real arm mover, so the deltoid and the larger muscles that lie over top of the cuff. At this point, now that we're doing more active motion with that patient, this is where you're going to see any kind of biomechanical faults being manifested, any compensatory patterns that patient has adopted since the surgery. So, a lot of times we'll see excessive upper trapezius activity where the shoulder is being elevated as the patient's trying to elevate their arm. So we want to try to quiet down that upper trapezius activity and restore the lower traps, the middle traps, the rhomboids, other periscapular muscles, in addition to isolating and activating that anterior deltoid. So getting everything to work in concert again, following the period of immobilization plus non-use of the arm. There's potential for a lot of biomechanical faults to occur. So at this point, we really want to kind of address these issues very early on and recognize that there's the potential for that to be there. So exercises that, any potential exercises for strengthening, like I mentioned, the rotator cuff, it's very important that we start with that. Internal and external rotation, using, whatever kind of resisted exercise that you like. Rows for, periscapular muscle control and stability. Y's, T's, and arrows can be performed for trapezius, strengthening. And then working more towards multiplanar and multiple muscle group exercises such as PNF patterns and more combined motions. And then also keeping in mind that working, with gravity eliminated can be maybe an initial step with patients who are having trouble with active motion against gravity. So following their 3-month time frame since surgery, now we can start to get into more exercises that are more sport specific or working more towards functional activity, whether it be for their job or recreationally, or just things that they want to be able to do at home that are maybe a little bit more advanced. So we're during this time we're getting into their full range of motion and trying to maintain this but not go beyond into a more unstable zone within their range. And of course, we're trying to increase and maintain any kind of joint stability and strength that they have, and continuing to progress them along, whether it be in the clinic or as they move into more of a home program. So, at this point, we're really working on our goals are going to be more specific to any kind of sport, overhead sports maybe, or functional activity, maybe work-related activities here too. All right, so just as a quick summary, the purpose of the protocol that we have and that any surgeon is going to have is just to set some sort of boundaries and some sort of limits on what we're working on and pace the progression of therapy so that we're making sure that we're keeping the repair that was done and the reconstruction that was done, keeping that safe and making sure that the patient has the best outcome at the end of the day. So, number one priority is protecting the repair. and then working on restoring their range of motion, restoring their strength, and getting that patient back to being functional with sports or any other kind of activity that they set out to do.